Welcome to this talk, and welcome back to Professor Robert Clancy. You are now well known to this channel, Professor of Pathology, Professor of Medicine, Consultant Physician for decades, published medical researcher, and of course, author. And we are going to be talking about using ivermectin in long COVID and long COVID post-vaccine syndrome.
In a sense, you have post-vaccine long COVID and post-infection long COVID. And certainly it's my experience, and talking to others, it's other people's experience, that those who get the post-vaccine long COVID, for simplicity, many of them will go on and, of course, get COVID. They get an exacerbation of near identical symptoms. And so there's this commonality of spike protein that appears to be involved. And at the end of the talk that we had the other day, I very quickly went through some of the ideas that I've been treating my patients with. And one of them, which I'm very excited about as a potential, was giving the individuals a trial of 4 to 6 weeks ivermectin. Now, this is not treating COVID, so we're not talking about ivermectin treating COVID here. We're talking about the use of a drug which recently, very recently, has been shown to have a high affinity to binding to the spike protein, which is in the vaccine and on, of course, the virus, because that's the attachment part of the virus to enter the cells of the body. And this has been done by a group in America, and initially also with in combination with a group in France. And it was initially developed as an idea, and we're talking about the last few months, when 3 studies, which I was part of one, but a very small part, 3 studies showed that if you treat patients who have low oxygen saturation with this drug, the oxygen saturation increases to normal in most cases within 24 hours, which made no sense if you're suppressing an inflammation. And this was then taken up by showing that if you take the red cells of you or me or anybody and add a little bit of spike protein, they all clump together. And this, of course, is making a very inefficient process of transferring oxygen from the lungs into the blood, and so the saturation goes down. But if you put small amounts of this drug in the test tube, the aggregation either disappears or doesn't happen. And there's a lot of really interesting studies that sort of come together when you understand this concept. My view was that if this is the case, then let's try treating patients. So I've treated a small number, maybe 6, 8 patients, and they've all had pretty much the similar results. It asks a lot of questions. It's been terrific in the short term. Obviously, there are many questions that need to be asked. We need to establish the safety of long-term use of a drug, which otherwise has been extremely safe, but we don't know. No, people haven't been treated every day for long periods of time. So there are these issues. There are the issues of how long does it work for a long time? Does the disease escape the use? But in many ways, it's exactly the same as the data we got several years ago when we were looking at athletes that I was talking about who have the Epstein-Barr or the glandular fever virus or infectious mononucleosis virus underpinning a chronic fatigue illness. And if you treat them with an antiviral agent, many of them, most of them, actually reversed their level of confusion or their cerebral cognitive issues, the energy-activated fatigue that we talked about. So I think the possibility is that we're starting to look at mechanisms that can expand into a whole range of related disorders of the chronic fatigue syndrome that is such a terrible problem in society with so many patients.
And this could be one of the good things that comes out of COVID, that we're thinking about pathophysiological mechanisms, disease processes, treatment modalities that could potentially apply to many, not all, but many chronic fatigue syndromes.
Yes, this is exactly my point and my view, that we learn all the time, and there's been such a focus and attention on COVID, rightly so, that we can now say, well, we're learning this in this context. Can we generalize this to other circumstances? And I firmly believe we can.
So you've been treating some patients with post-vaccine injury, Robert. Now, we know that some of these are purely post-vaccine injury because they have spike protein antibodies in the absence of nucleocapsid protein antibodies. Some of them are long COVID because they've had the infection, and some of them, I hate to use the term, but are hybrid post-vaccine and long COVID syndromes. Now, your patients that you're seeing, we've got symptoms here like chest pain, passing out, fatigue, cloudy brain. Can you just tell us, in a sense, describe the suffering and the clinical features that these patients are presenting to?
Now, this is actually the data that the patient brought in to my clinic yesterday, actually. what I've asked them to do is to take the symptoms that concern them and give a scale 0 to 5, where 0 would be fantastic, perfectly normal health. 5 would be incapacitated, they can't get out of bed, or as bad as they can imagine.
Yeah.
And then make up for each of them, take their symptoms and make up a scale that's relevant to them. And you can see this particular person, she put chest pain, passing out. The particular person had POTS syndrome, which many people would know about, where you're passing out all the time, you get autonomic nervous system involvement, a volume depletion of fluids in the body, and that comes together with postural hypertension, which means you stand up, you can faint.
So in other words, when you stand up, your heart goes 90 to the dozen.
That's right.
And you feel dizzy and want to fall over again.
Dizzy and fall over. So
horrible.
What here is passing out, which was a big issue with this particular patient. Energy activated fatigue, and what they're calling cloudy brain fog, which I call cognitive impairment. And so you can see that this particular patient...
They were really pretty ill, weren't they?
Extreme problems, completely unable to leave home, get up, go to university, all those sorts of things. This is not a graph I've drawn. It's a graph from those figures that you've just seen. And you can see dramatic changes. Now, what you're seeing is a cluster of 4 lines. Each of those lines relate to the different symptoms that we went through in that table. Now, I can't remember, I think I gave them...
That's the chest pain, passing out, fatigue, cloudy brain fog.
So they're the classic symptoms of post-viral fatigue illness. And what you've seen there is basically a complete remission, complete improvement. A person who was incapacitated to a person who was functioning pretty much normally after 5 or 6 weeks of taking this particular drug. Now, the idea was to then stop the drug and see what happened. And as you can see, there's essentially 10 days or so where there's a maintenance of complete remission, and then all the symptoms started coming back. I'm showing you this as a typical outcome of all the patients I've treated. Now, as I said, it's only 6 or 8 people, and some seem to get more complete benefit than others. But this is, I'm showing you this because it's it's the best graph that I would...
Well, it's totally stunning, Robert. We've got appalling symptoms, really high lines. You start the ivermectin, and you might expect it to affect 1 or 2 symptoms, but they all get dramatically better, to the point where this patient basically resumed a normal life again.
That's exactly right.
And then a few days after stopping taking the ivermectin, the symptoms came back again.
That's right. And if you look at the symptoms are changing in parallel, which strongly suggests that what you're seeing is a common mechanism.
Yeah.
And as I said, the reason that I've been doing this is the studies by my colleagues in the States in particular, showing this high affinity. What they did is they used computer approach. 4 different groups did this, and they screened all sorts of drugs available to see which one bound the tightest to spike protein. And this is called in silico. They measure the actual binding affinity.
Yeah.
And the drug that came out in all of these, right above everything else, was this ivermectin.